The objective of the talk today is to discuss the new immunosuppression agents utilized in solid organ transplantation, define the role of everolimus in liver transplantation based on the new clinical evidence, describe the adverse effects and monitoring parameters of belatacept, and then finally recognize the differences in pharmacokinetic parameters and dosing of Astragraf SXâ and Parenteral. So moving along, before we get into the new agents, I just wanted to provide a brief review of the history of immunosuppression. So really, before the 1980s, the only medications we had used for maintenance immunosuppression were azathioprine and corticosteroids. So they were really the backbone of immunosuppression therapy. In 1983, cyclosporin was approved for use in kidney transplant, and it really revolutionized transplantation, not only in kidney transplantation, but in the future organ transplants that began using cyclosporin. The great thing about cyclosporin is it extended graft survival and patient survival. However, it had many toxicities, is associated with many toxicity, particularly nephrotoxicity is probably the most common side effect, the most bothersome toxicity that we are still trying to manage. In the 1990s, further agents were developed. These agents still have their own toxicities that we're dealing with. They have improved patient graft survival, but there's still many works to be done into minimizing toxicities. Between the years 2000 and 2010, there's really only one medication that was approved for use of transplantation. It was everolimus or rapamycin, which is a new class at the time, which is the mTOR inhibitors. And then in 2010, we saw another mTOR inhibitor, everolimus, become approved, following with belatacept, and then in 2013, we recently had Astragraf approved. So I'm really going to focus the remaining presentation on those three immunosuppression agents. Just briefly, talking about the categories of immunosuppression therapy, every organ transplant type and center have their own specific regimens based off of protocols, based off of data. So immunosuppression regimens are really patient-specific in the sense of taking account of other comorbidity disease states, also risk of rejection, side effects, profiles, drug interactions, and finally cost of these therapies. On average, a lot of patients, depending on what type of organ you receive, may receive induction therapy, maintenance therapy, and rejection treatment. I want to spend a little bit of time talking about maintenance therapy. Again, depending on the organ type, most maintenance therapies are composed of 3 different agents. So as Shana mentioned, I work in lung transplant, and we always keep our patients on a 3-drug regimen. In liver transplant, though, depending on the indication, sometimes it can go down to monotherapy and just be on a calcineurin inhibitor. So speaking of calcineurin inhibitors, those include cyclosporin and tacrolimus, and that's really the backbone of our maintenance therapy. And we usually use them in combination, potentially with antimetabolites, which include mycophenolate and azathioprine, or corticosteroids. The mTOR inhibitors and the co-stimulation blockers are relatively newer classes of medications, and sometimes we can use that as alternative therapies to the calcineurin inhibitors. Occasionally, mTOR inhibitors can be used in combination with calcineurin inhibitors. So I'm really going to focus on the 3 new medications that came up within the past 3 years: everolimus, which brand name is called Zortress, belatacept, which is Neurologic, and then tacrolimus extended release, which is Astragraf SXâ. So our first pearl is in regards to everolimus or Zortress. So this was the second mTOR inhibitor that was approved. It was actually approved in renal transplant in 2010, and it had a unique mechanism of action. And it gets kind of confusing because everybody thinks that everolimus and sirolimus, which is the other mTOR inhibitor, works the same as tacrolimus, which is actually a calcineurin inhibitor. So the mechanism of action is very unique to this class in the sense that it binds to the FK binding protein 12, which inhibits the activity of mTOR. This leads to the inhibition of IL-2 activation and the proliferation of T and B lymphocytes. In regards to pharmacokinetic properties of everolimus, Actually has a shorter half-life if you compare it to sirolimus. Sirolimus is usually half-life is about 62 hours, so it's once daily dosing, while everolimus is always twice daily dosing. It is substrate of CYP3A4, and so it does have a lot of potential drug interactions, so that's always a challenge when patients are on this type of therapy. In regards to adverse reactions, the most common seen are peripheral edema, hypertension, leukopenia, and proteinuria. And as I mentioned earlier, this medication was just recently approved, or I haven't mentioned this before, but as I said, it was approved in renal transplant in 2010. Recently, in February of 2013, it was approved for liver transplant, and we're going to look at the clinical evidence regarding that. And so why do we use everolimus in liver transplant? Well, we're trying to give it, we try to have a renal sparing effect, and that's the reason why we use potentially an mTOR inhibitor in liver transplant. There's a high incidence of acute renal failure in liver transplantation. It can be up to 80%, and a lot of times that's just because of how sick the patients were pre-transplant, that a lot of times throughout, if they make it through the surgery, they have some components of hepatorenal, and so that contributes to the acute renal failure. Long-term, the risk of chronic renal insufficiency is up to 70%, again, because of the risk of their acute renal failure that they may have had initially, and also with the concomitant medications that we get. The question in using everolimus in liver transplant is to define the optimal timing. With the de novo use, we got a little scared that using everolimus is de novo because of our experience with sirolimus. Sirolimus was initially studied as using a de novo, and they found that it can increase risk of hepatic artery thrombosis, which now has a black box warning on sirolimus. So they thought it was a class effect, so really everybody prefers not to use de novo. And we also are concerned with wound healing complications when using these agents as de novo. So there was one trial that looked at late conversion to liver transplant patients on everolimus, and this was a trial that was done in patients who were at minimum 1 year out from liver transplant, and they could range to up as far out as 6 years after transplant. And really the main outcome they were looking at is improvement of renal function. And when they looked at this study, it was everolimus. They converted the patients from CNI inhibitor, which was tacrolimus, to everolimus, and then they compared it to the control arm. And they found that there was really no difference in renal function. And there was two conclusions behind this trial. The first conclusion is that many patients in the control group, the investigators at the different centers actually adjusted their levels down once the renal failure became known, and so it screwed up the power of the study, and so they felt like more patients were being adjusted down to try to preserve the kidney function, so they couldn't tell the difference. And then the other thought was that at some point in time there could be irreversibility of the renal function, depending on how far out we are. So another study that was looked at was a prospective multi-center trial, and this looked at actually using everolimus after 30 days after transplant. And so this was a trial that included patients who had good graft function, a GFR greater than 30 mils per minute, and had therapeutic tacrolimus levels. So again, these patients were randomized to 3 groups after 30 days, and the first group was the tacrolimus elimination group. And in this group, they were started on everolimus, and their levels initially were 3 to 8 nanograms per ml. And then at month 4 after transplant, they withdrew the calcineurin inhibitor, and they increased the everolimus levels to 6 to 10. The second group, again, they added on everolimus, and then they reduced the tacrolimus levels. And they kept the same tacrolimus levels and everolimus levels throughout the study. And then the final group was the tacrolimus control group. So these patients received a little bit higher doses of tacrolimus within the first 4 months, and after 4 months, they reduced the therapeutic levels to 6 to 10. And they looked at differences 12 months after randomization. They looked at biopsy improvement projection. They looked at death, and they looked at renal function. And the renal function was a secondary outcome. So going to efficacy and safety endpoints, in the tacrolimus elimination trial, they found that there was a higher incidence of biopsy-proven acute rejection 4 to 6 months after withdrawal of the calcineurin inhibitor. So there was a safety committee that actually stopped this arm because of the higher risk of acute rejection. And so they really looked at just the safety aspects between the everolimus plus the reduced tacrolimus and the control group. And they found that there was a difference in renal function in the everolimus group, that everolimus, that group had 8.5 mils per minute better renal function, or GFR, than the tacrolimus control group. In regards to side effects, we did see higher peripheral edema and leukopenia in the everolimus group. So in conclusion, and this is a nice graph of looking at the renal function of the difference in that was seen with the everolimus group. So really the conclusion was that everolimus plus reduced tacrolimus demonstrated similar efficacy in achieving the composite efficacy point and decreasing acute rejection, and they had similar safety profiles between the control group plus the everolimus plus reduced tacrolimus. So it seems to be that everolimus could be a reasonable alternative immunosuppression agent to patients who may have renal insufficiency. So moving on to our next agent, belatacept or Nulargic. So this is a new agent. Actually, it's the first medication in this class. It's a co-stimulation blocker, and this was approved in June of 2011 for renal transplant only. This is, again, a unique mechanism of action as it blocks the CD86, which can prevent T-cell activation. And this is an injectable product only, so that kind of comes in to be a unique challenge in giving this patient, giving our patients this immunosuppressant agent, because they have to go to an infusion center to receive it. And if we look at the dosing here, the dosing can be challenging in the sense that initially they receive a larger dose, 10 milligrams per kilo, up to 3 months, and then after 3 months, once a month, they receive a 5 milligram per kilo dose. Again, they have to go to an infusion center to receive this infusion. Infusion is usually about 30 minutes, and we don't need to do any pre-medication with the belatacept infusion. In regards to drug interactions, it can increase mycophenolate concentrations up to about 20%, which really, at U of M, we don't check mycophenolate concentrations, and so we find it clinically not significant per se in this scenario. Regarding adverse drug effects, we see that it can cause anemia, diarrhea, urinary tract infections. It was more common primarily, I think, because this was studied in kidney transplant patients, and there are a high risk of having urinary tract infections anyway. We saw peripheral edema and hypertension. Just want to note that, as you see here, there's no nephrotoxicity here, and so that's what makes this agent appealing to the transplant community, because it does not cause nephrotoxicity. So looking at the clinical evidence, there was 2 phase 3 trials that looked at the use of belatacept in renal transplant patients. The first one was the BENEFIT trial, and that looked at standard criteria donors, and then the BENEFIT EXT trial looked at extended criteria donors. And these were multi-centered, randomized trials that randomized patients to 3 groups. The first group was a more intensive, so they actually received the higher dosing regimen for up to 6 months, and then they decreased down to the maintenance phase. The less intense received 10 milligrams per kilo for 3 months, and then going down to the maintenance phase. And then the cyclosporin group was our control group at the time. If we look at the primary endpoints, they looked at acute rejection, GFR, and patient and graft survival. The results, they really had they showed non-inferiority in the aspect of death, or the graft survival, that there was no difference between the 3 groups. When they looked at renal function, or the GFR, they found that both belatacept groups, the more intensive and the less intensive, had better renal function. So the GFR, the mean was about 64 mils per minute, while in the cyclosporin group, the GFR was around 50 mils per minute. So that's really clinically significant. We can have a whole discussion about that, but that they did see a difference in that. However, when we looked at the acute rejection risk, we found that there was more acute rejection in the more intensive group, which is very interesting because you think that if you receive more of this medication, you should have less rejection. So that was an interesting finding that they found in both of these trials. And another interesting finding they found was in regards to the safety aspects, that they found more cases of post-transplant lymphoproliferative disorder, or it's called PTLD, in the belatacept groups versus the cyclosporin group. So they found 10 cases versus 1 case in the cyclosporin group, and half of these cases had CNS involvement. So the incidence of PTLD in immunotransplant anyway is less than 3%, and patients having CNS involvement of PTLD in immunotransplant is about a 10% risk. So it was interesting that they had a 15% incidence of CNS disease, and it was a high incidence as compared to the general renal transplant population of developing PTLD. So based off of the study data, the FDA placed a black box warning in belatacept about how it has an increased risk of PTLD, particularly in Epstein-Barr virus seronegative recipients. So if you are seronegative recipient, primarily PTLD can occur with anybody who has an Epstein-Barr virus primary infection. So they were concerned that these patients would contract Epstein-Barr virus and then develop PTLD. So they have limited or contraindicated anybody who is EBV negative and receiving belatacept. And they also put a increased risk of progressive multifocal leukoencephalopathy, or PML. Due to the findings of these studies in the sense of showing that there's more acute rejection with using belatacept and having the cases of PTLD, the only way that they granted approval of this drug is that they have the manufacturer have a risk evaluation monitoring program, or the REMS program. And so this was actually the first immunosuppression agent that came to market that required a REMS program. The only other immunosuppression agent that we use in transplant that has a REMS program is mycophenolate. And this came into effect a couple years ago when they found out that mycophenolate could lead to more birth defects. And so that now has a REMS program in that aspect. So this was just a new development in the sense of FDA is now requiring a REMS program for this immunosuppressant agent. So with the REMS program, there's actually 2 major components to be aware of. The first component is that a medication guide needs to be given to every patient after discharge and with every monthly infusion. So every month, the patient should be receiving a medication guide, and it goes through adverse drug reactions of this medication. It talks about adherence to the medication. It talks about efficacy data, and it also talks about signs and symptoms of PTLD. Another important component was a communication plan, and so the manufacturer had to make sure that they provided communication to everybody in the transplant community about the risk of using belatacept. So this includes a healthcare professional letter, also includes having the major journals have articles on this, and so that was part of the communication plan. They also require that at every infusion that the provider goes through a pre-infusion checklist. So if they're having any particular symptoms, they should not be receiving that infusion that day. So that's just another component. So it is pretty labor-intensive and time-consuming for a transplant program to have a REMS program. Obviously, it's for good use of the safety aspects, but can definitely increase the amount of work. The FDA also recommended using the MedWatch program to report any adverse drug effects of the belatacept. And then they also wanted to review the REMS annually every year for the first 5 years to see if there was any other incidence or increased incidence of PTLD post-market. So just a little bit of pearls in the monitoring and education of belatacept. So the most important thing is it's only used for EBV seropositive recipients only. So that's the strongest contraindication it has, or that's the strongest indication that they should have. It's in black box warning all over the website and the package insert. It's really important to use to avoid using higher than recommended dosing. So to really use the dosing that's available in the package insert, and that's based off of the less intensive dosing that was seen in the trial, and that's the 10 milligrams per for up to 3 months, and then 5 milligrams per kilo every month thereafter. And then to counsel patients on cognitive and behavioral signs of PTLD, including mood or vision changes, confusion, any types of gait and speech problems. And I skipped over this, but infusion reactions were really rare. They weren't really seen, only hypo or hypertension, and at that point you could slow down the infusion. So other than that, it's fairly well tolerated from that standpoint, but considering the amount of immunosuppression it provides and the risk of PTLD is pretty high. So moving on to the last agent I'm going to speak upon today is Astragraf, which is the extended release tacrolimus. And we were really excited for this to be approved in the sense of that it will help non-compliance of our patients, because this is a once daily dosing tacrolimus, and so that's the idea of why it was pushed to be approved. It actually has been available in Europe for many years now. It is only FDA approved in renal transplant patients. As of right now, there is some data out there in regards to liver transplant and lung transplant too, but it's not FDA approved in those indications. Just looking a little bit quickly at the pharmacokinetic parameters and de novo use. So that's basically being used right after transplant, that the AUC is pretty similar after day 1. Day 1 is actually lower. And then within 14 days, the AUC is pretty similar. The Astragraf actually does seem to require a little bit higher daily dosing than the immediate release tacrolimus. Other thing to note is that if it's taken with food, the AUC can be decreased by 30%. So the package insert does recommend having patients take it on an empty stomach to not have that decrease in 30% of the AUC. There's another group that looked at conversion of the tacrolimus from the Prograf brand to the Astragraf, so from the twice daily dosing to the once daily dosing. And they really found that there were similar AUCs and troughs in regards to the conversion, and they felt like the current drug monitoring assay that we use routinely would be applicable to the Astragraf therapeutic drug monitoring. So they found, but it is not FDA approved to be used for converting from twice daily to once daily dosing. So in summary, of the Astragraf, it's not interchangeable. It's not interchangeable with immediate release tacrolimus, and that's the main component, the main pearl I want to communicate. Because if a patient comes in and they're on the Astragraf, then they really need to remain on the Astragraf. It's not one that should be converted back and forth between the immediate release and the extended release. Because you could need higher dosing of the Astragraf to meet the therapeutic target, so it's just really important to continue on the same dosage form. If you have to switch a patient, really what the recommended is frequent monitoring to make sure that we're still achieving therapeutic levels. And in regards to the meal comment of empty stomach, I know I have a lot of patients who are lucky we can get their medications down at any point in time, so as long as I feel take them consistently, we can monitor for that decrease in the AUC in the sense of monitoring levels, and we can always adjust the dose at that point in time. And then to me, I think is a big deal is that it can cause some confusion and medication errors because they have similar coloring between the Astragraf SXâ and the brand name Prograf. This is the generic, which is slightly different, but again, I think that they're pretty similar, that you can still have medication errors in regards to this. So just in summary and conclusion, overall, initiating everolimus after liver transplant in liver transplant patients really does seem to provide renal protection without sacrificing efficacy, but it should only be done at 30 days post-liver transplant, and also it should be in combination with reduced tacrolimus to maintain efficacy. Belatacept requires a REM program because of the increased risk of PTLD, and just educating patients about the signs and symptoms of PTLD, and educating other healthcare providers in the sense of even like the infusion centers of where these patients may be getting infusions is important. And lastly, Astragraf SXâ is not interchangeable with the Prograf, and that due to the appearance, medication errors could happen, and frequent monitoring is recommended if they do have to switch between the immediate release and the extended release.
My name is Danielle, and you are all probably wondering why surgery services, so I had a very active role in helping the physicians write parenteral nutrition orders on a daily basis. And so my goal today really isn't to talk about caloric needs, because that's very controversial, what equation you might use to calculate that, but really my goal today is to get everyone to think about the types of questions they should ask themselves when they see a day one parenteral nutrition order. So I want to review the appropriate indications for parenteral nutrition, discuss safety considerations when initiating parenteral nutrition, and finally describe what a pharmacist's role is when initiating parenteral nutrition. So I graduated from pharmacy school a handful of years ago, but one thing that I definitely remember is learning that if the gut works, use it. So always keep that in mind. If the patient can obtain nutrients enterally, that they should, and that parenteral nutrition is a second line way to obtain nutrients. So we'll start off with the case. DK is a 54-year-old well-nourished female, status post-operative day 10 from a Withdrawal procedure. So I had a lot of patients that obtained Withdrawal procedures. So for those of you that are not as familiar with the Withdrawal procedure, it is a pancreaticoduodenectomy. So essentially they take off a portion of the pancreas along with possibly a portion of the stomach and a lot of the other organs in there, and they attach it to the jejunum. And so basically it's a really big abdominal surgery. The patient has a history of GERD, newly diagnosed pancreatic cancer, that's why she's having the Withdrawal, and no past surgical history. She's allergic to eggs. Current inpatient medications are Dacrosate, sliding scale insulin, famotidine, and maintenance fluids of D5 half normal at 80 mL an hour. So the first year surgical intern calls you and says his attending wants parenteral nutrition for this patient. Can you help him with the order? So first we want to determine if DK's parenteral nutrition is even appropriate at this point. So Aspen, American Society of Parenteral and Enteral Nutrition gives us some good guidelines, good indications to when parenteral nutrition is indicated. So diffuse peritonitis is a good indication for parenteral nutrition. A lot of times you get peritonitis from a perforation somewhere in the GI tract, so you're not going to want to feed someone who has a perforation somewhere along the GI tract. Intestinal obstruction, so if you feed someone with an obstruction, the food is not going to go through the GI tract. Intractable vomiting or diarrhea, so if you feed someone with these two things, you might be making it worse. Ileus, again, food's not going to go through if your patient has an ileus. You don't want to feed ischemic gut. Short bowel syndrome, so these patients, they're usually eating enterally, but they're not able to obtain enough nutrients just from enteral eating. And then gastrointestinal fistulas. So depending on where your fistula is in the GI tract, feeding a fistula, first of all, is not going to let it heal, and second of all, can increase output from that fistula, which causes issues as well. So there are guidelines from the Society of Critical Care Medicine, and again, the American Society of Parenteral and Enteral Nutrition, that kind of help us evaluate and assess what is appropriate, when it is appropriate to give patients parenteral nutrition. So I just listed here the grading system for completeness sake. So a grade A is the best supported recommendation by the evidence that we have, and then E is the least supported and maybe the expert opinion. So the first recommendation they had is in a previously well-nourished patient, PN should be initiated after 7 days of hospitalization when enteral feeding is not possible. So of course enteral feeding is preferred, but if a patient, a critically ill, well-nourished patient previously is hospitalized for 7 days and enteral feeding is not feasible, then it makes sense that it would want to start parenteral nutrition. They also say that in a previously malnourished patient where enteral a recent weight loss of greater than 10 to 15%, or less than 9% of ideal body weight. So I kind of wanted to provide some of the literature that the guidelines use to make these statements. So this first study was used to evaluate complications with parenteral nutrition, including mortality. And so this was a meta-analysis that the investigators did Medline searches on studies that included critical care and surgical patients, and they looked at parenteral nutrition versus standard of care. And they defined standard of care as usual oral diet plus intravenous dextrose, so like maintenance fluid. They found that there wasn't an increased mortality with parenteral nutrition, and they actually found that there was a trend towards lower complications with parenteral nutrition. But they kind of found that the subset of those patients that actually had the lower complications with parenteral nutrition were those malnourished patients. So that's why in the previous slide the recommendation was to start parenteral nutrition as soon as possible in a previously malnourished patient. They also found that complications were higher in studies that used lipids, but there was no mortality difference between the lipid group and non-lipid group. And there was a significant increase in complications and mortality with the critically ill population versus the surgical population that they were looking at. So in conclusion, there are no difference in overall mortality with parenteral nutrition, but it appears that those patients that benefit the most with parenteral nutrition earlier rather than later are going to be those patients that are from the get-go malnourished. Lipids, methodology, patient population, and the year of the study impacted these results, and that's one of the comments that the authors had in this paper. Another study that kind of influenced the guidelines thoughts were a study that looked at prospective randomized clinical trials that evaluated nutrition interventions, complications, and mortality. So again, this is another meta-analysis, so not a lot of randomized controlled prospective trials that we have that make up our guidelines. But these authors also did a Medline search of studies that compared enteral nutrition, parenteral nutrition, and standard of care. Their definition of standard of care was a little bit more ambiguous. They kind of just said standard of care meant limited nutritional intervention. So of the 27 studies and a little over 1,800 patients, they found that in terms of increased infection, it was greater in the parenteral nutrition group. But when they compared parenteral versus standard care, they actually found an increased mortality in the standard care group. Again, supporting the fact that if you have a malnourished patient, using parenteral nutrition earlier makes sense. So in conclusion, there is a decreased rate of infection with enteral nutrition and standard of care, but those patients, again, who are malnourished, there was an increase in mortality and trend towards more infections in the standard care group. More recommendations. So patients undergoing major upper GI surgery, so examples like an gastrectomy or pancreatectomy, these patients should receive parenteral nutrition 5 to 7 days pre-operatively if malnourished, and continued post-operatively until essentially they can have enteral nutrition. So at least in my practice when I was covering general surgery, a lot of these patients weren't captured because as a pharmacist I would see them post-op day 1. So I had a really hard time implementing early parenteral nutrition because I just didn't know they would even be there. Nutrition or parenteral nutrition, if nutrition has been delayed for 5 to 7 days already, and the patient can't be fed enterally, then it's a good idea to potentially at least start thinking about parenteral nutrition or initiating it. And then if duration of use is anticipated for greater than or equal to 7 days, it is a good idea. It promotes the use of parenteral nutrition probably not there, but you really have no way of knowing that. So some more literature. This study looked at the use of postoperative adjuvant parenteral nutrition in patients undergoing pancreatic surgery. This was a prospective randomized trial that looked at major pancreatic resection. The adjuvant nutrition, parenteral nutrition that was provided was on post-op day 1, and that was until the patients could take enterally over 1,000 kilojoules per day. The parenteral nutrition that was provided was 1 gram per kilo of protein calories, and then 30 to 35 kcals per kilogram of non-protein calories. So to kind of gain some perspective, I guess if you're not used to doing this very much, the protein is not a ton for someone who just had major abdominal surgery, but the non-protein calories, that's a pretty good amount of non-protein calories. So the results from this study was that there was a higher incidence of major complications in the adjuvant parenteral nutrition group, but there was no significant mortality differences between the two groups. So in conclusion, post-op adjuvant parenteral nutrition is really not recommended for those patients undergoing major pancreatic surgery. So what are some of the complications that you can expect, or at least need to look out for with parenteral nutrition? You can have hyper or hypoglycemia. So you're giving someone a continuous dextrose load, and so especially if you have a past medical history of diabetes, you don't know how they're going to tolerate that, and you can make them hyperglycemic. In our Whipple patient here, they had part of their pancreas resected, so sometimes those patients in particular don't tolerate parenteral nutrition the way they would before they had the surgery. Hypoglycemia, you can get rebound hypoglycemia after you stop the infusion of parenteral nutrition. Hypertriglyceridemia from your lipids. Refeeding syndrome, which we'll talk about a little bit in the next couple of slides. Hypercapnia, hepatic steatosis, cholestasis, cholestasis, acid-base issues, and then the complications you can get like pneumothorax from the lines that you replace for parenteral nutrition. Allergies to look out for, soy, eggs, and safflower. These are things to look out for in terms of giving patient lipids. So perhaps you might have to hold lipids if the patient has a soy or egg or safflower allergy, depending. Hopefully they don't need parenteral nutrition for very long and they can wait. Other alternatives, maybe get allergy on board and they can test dose the patient to see if they can tolerate the lipids, or last resort, rubbing vegetable oil or any sort of oil that's high in essential fatty acids may have to resort to. I've never had to resort to that, so bringing us back to the question, is DK's parenteral nutrition order appropriate? So the resident tells you, or the intern tells you that this indication is for post-operative ileus, and this is post-op day 10. So this seems pretty reasonable to me that patient hasn't eaten for 10 days, still has this ileus, and so it's reasonable to initiate parenteral nutrition at this point. So one of the first thoughts in my mind when I'm reviewing a parenteral nutrition order is, does the patient have appropriate line access to run the parenteral nutrition back through? So patients should have a central line for parenteral nutrition. Likely they're going to have a PIC or a peripherally inserted central catheter. You can do peripheral nutrition, but I would really avoid this. You're not going to meet the patient's calorie goals due to osmolarity and the ability to tolerate through a peripheral line. So I won't really be talking much about peripheral or at all about peripheral nutrition. So I know during my residency director actually went through what a central line was, and I found that to be very beneficial. So I just wanted to take a minute to do that. So a central line basically has to terminate in the superior vena or the right atrium. And there's only a handful of different places that they usually start the central line. So the right or left internal jugular vein, or IJ, you may have heard of before. External jugular vein, so EJ, subclavian, right or left subclavian. I just wanted to point out the superior vena cava there. So those lines are right through those vessels and then down into the superior vena cava. The basilic vein is usually where they start PIC line. They run it up through the basilic vein and then eventually down again into the superior vena cava. And then femoral veins, we can start central lines. Less desirable points just because of the location and the cleanliness of the groin area to start a central line. You can always tell if you don't know if the patient has a central line, you can always tell by a chest x-ray. They have to get a chest x-ray to confirm that the line is placed in the superior vena cava. You can read the radiology report. You don't have to try to look at the picture to place appropriately. So this just is kind of reiterating different lines. So you can see that they're all terminating down there at the central vena, or the SBC. I also wanted to point out, and this has come up as a point of confusion several times, a midline catheter or a midline PIC, it's often referred to, is not a central line. Just because PIC is after midline doesn't make it a central line. It does not terminate the superior vena cava. It's shorter than that. All right, so feeding weight, I don't want to get too much into this because this kind of goes into what weight do you use to calculate your calorie needs, and everyone does it differently, and everyone does their own equations. But the main point that I wanted to point out, and my residency director actually would always tell me this: you don't feed fat, you don't feed water, and you don't feed weight you don't have. So keep that in mind. If you have a 150 kilogram patient, you see an order come through that's trying to feed 150 kilograms worth of calories, that's wrong. So just keep in mind the weight that they're using to try to calculate calorie needs. So how much fluids do you use? This depends. Sometimes physicians will have preference. Sometimes they just ask how much fluid can I have. A lot of times they don't know what you're talking about. So what I kind of do to try to gauge is I look at what their maintenance fluids are and how much they're receiving. Usually it's around 2 years, so I know I have at least 2 years of liquid. But you also need to keep in mind their past medical history. Is the patient on dialysis? Does the patient have congestive heart failure? Because those patients are not going to be able to tolerate as much fluid as a normal patient would. Again, look at what the patient is receiving and it can kind of guide you. Dextrose content. So this is important when you're trying to look out for hyperglycemia. As your dextrose infusion rate goes up, the risk of hyperglycemia is greater. So again, I put Whipple on here because this patient might react differently to the dextrose load that you're giving because of the procedure she had. So again, use your maintenance fluids to guide you. This patient's getting 80 of D5, half normal an hour, so that's almost 100 grams of dextrose. If you see that she's not having hyperglycemia from that, then she might tolerate that or a little bit more to start off with. One of the biggest mistakes that I always see is that you start parenteral nutrition and the patient still has their maintenance fluid. So you're giving them a bunch of dextrose in their day 1 TPN, and then they're also getting their severe pulmonary, cardiac, and neurologic decline in these patients. So how do you prevent it? First, you assess for risk. You assess if the patient is malnourished. And so that's why, one of the reasons why on the first day of initiating parenteral nutrition, you don't start the patient out on their goal calories. So you're more conservative just in case, especially in a malnourished patient, that they may refeed. So again, use your maintenance fluids to guide you. Our patient is eating about 100 grams of dextrose at this point. If you don't see electrolytes dropping from that, you can probably give a little bit more dextrose on day 1, and then advance to goal over the course of a couple of days. And then if you see someone refeeding, don't be bashful with your electrolyte depletion. Be very aggressive. You may need to put more in the parenteral nutrition bag up front. Realizing though, once the patient is repleted, that you might need to back off on some of those electrolytes. Also keep in mind medical history. If the patient on hemodialysis or they have acute renal failure, this is going to impact how much certain electrolytes you're going to put in the parenteral nutrition bag. I'm very, very conservative with the hemodialysis patient and adjustments to their pay cost and bag because they accumulate very quickly. And remember, if you err on the side of caution and don't put maybe an aggressive amount of electrolytes in the parenteral nutrition bag, you can always replace outside of that bag. Whereas if you have a hyperkalemic patient, you're going to have to stop parenteral nutrition. Cycling. So day 1 should always be 24-hour cycling. The only time I ever don't use 24-hour cycling on day 1 is essentially a patient that has come in stable on a home regimen, so it's really not day 1 for them. You have to watch for hyperglycemia as you cycle the TPN, and on the later days, your dextrose infusion rates will increase and potentially even have hyperglycemia. And then you don't know necessarily if all your patients can tolerate the increased fluid load and the decreased amount of time. So in conclusion, appropriate access is imperative. We always need to consider the indication for the TPN and if it's appropriate, because there are a lot of complications that you can see with parenteral nutrition use. And fluid, electrolytes, and allergens need to be reviewed before initiation.
I'm going to be talking to you today about withdrawal. These are the objectives of what I'm going to be covering today. Talking about neurotransmitters. It's important to try to get an appreciation for the pathogenesis and pathophysiology of alcohol withdrawal, because I think it has huge implications in terms of management, which types of agents we could potentially use. I'm going to talk about something called symptom-triggered treatment of alcohol withdrawal, and then I'll talk about some key medications with respect to management. So with respect to pathogenesis, there's a bunch of different neuroreceptors that alcohol can attach to, and then over time, in chronic alcoholism, lead to changes in those receptors that will put a patient at risk for alcohol withdrawal syndrome. The glutamate NMDA receptors are a site for alcohol attachment. When that occurs chronically over time, you get receptor upregulation. Patients begin to develop tolerance to that. And then when the alcohol is abruptly withdrawn, then you get the excitatory response that is associated with the NMDA receptor. And so then you get tachycardia, hypertension, those kinds of symptoms. Another receptor that alcohol can bind to is the inhibitory receptor, the GABA receptor. Again, in chronic alcohol use, you get a change in the receptor response such that you get upregulation, so that chronic alcohol use leads to tolerance. You can see patients who would, in another setting, might not be able to tolerate the extent to which the alcohol is attaching to those receptors. And then when you have the alcohol withdrawn, that leads to the blunting of the inhibitory effect of the GABA receptor, and then you get an excitatory effect. This is a centrally mediated, get the CNS symptoms, agitation, psychomotor activity, and potentially seizures. Yet another area or receptor that alcohol can interact with is the alpha-2 receptor. So along with alpha-2 is an inhibitory receptor for sympathetic drive. Quantity is an agent that we use frequently in managing infection patients with alcohol withdrawal. And so in this setting, again, you have altered sensitivity of the alpha-2 when somebody has chronic exposure to alcohol. And then when the alcohol is removed, that loss of sensitivity means that you lose that feedback inhibition of sympathetic drive, and so you get excess sympathetic drive, and again, you get huge sympathetic response. There are other neurochemical systems that can impact alcohol withdrawal. I'm not going to go into detail on these, but these, I think, help inform us in terms of other potential interventions that can be used, other medications that could perhaps be studied in terms of managing alcohol withdrawal syndrome. This is a diagram which kind of attempts to pull most of that stuff together. It's not comprehensive, but just quickly, alcohol withdrawal would be, like I said, decrease in the GABA inhibitory pathway, increase in the NMDA excitatory pathway, increase in the sympathetic drive. The stress response leads to increase in cortisol release, all of that leading to the clinical symptoms that are associated here, including hallucinations, delirium, potential with PTs, and even seizures. The diagnosis of alcohol withdrawal syndrome generally is comprised, by definition, two of these symptoms. So you can see here they're essentially sympathetic, autonomic symptoms. CNS, oops. Did I do that? I'll try to be careful. Anyway, two of these symptoms in conjunction with withdrawal of alcohol ingestion, and that is essentially the diagnosis of alcohol withdrawal syndrome. There are classically 4 stages of alcohol withdrawal syndrome that are defined. They're not unique or discrete in any way. There could be significant overlap in these, but just to go over them, stage 1, within 68 hours, you begin to see the sympathetic symptoms, nervousness, nausea, vomiting, tachycardia, and perhaps hypertension. That evolves into stage 2, which is essentially increase in the severity of the stage 1 symptoms, plus you can get some hallucinations. The hallucinations in stage 2, by the way, are not considered to be associated with some form of delirium. Generally, patients will have, still have cognitive function. And so you can be in a patient's room and the patient says, I see snakes on the wall. And I know they shouldn't be there, but I see them. So they still maintain cognitive function, and they recognize the hallucinations that they're having. Stage 3, again, similar to stage 2, that can be associated with emergence of seizures. Most of the time, it's said that patients don't seize within the first 48 hours. However, that certainly is possible. Same thing with delirium tremens. That is generally considered to be 3 to 5 days and beyond. While delirium tremens can occur within the first 48 hours, it's felt not to be typical. So delirium tremens, I think everybody in the room has heard of delirium tremens. Most severe form of alcohol withdrawal syndrome associated with increased mortality historically. More of late, I think it's pretty rare that you would have somebody actually die of delirium tremens because we're well aware of the alcohol withdrawal syndrome and we treat early and often. But this is essentially the definition of delirium tremens. In this case, when you do have hallucinations, you do have altered consciousness, you do have decreased cognitive function. And as listed here, patients can have disturbances in language, memory deficits, etc. It can, like I said, develop typically after 48 hours. the ultimate diagnosis is aided by knowing the history of the patient, knowing their alcohol history, knowing labs. However, having said that, I suspect that a number of you have probably seen patients who come in who deny alcohol ingestion, and then over time, not very long, you tend to realize that, oh, you know what, this patient's going into alcohol withdrawal, and we treat that. There's different scales available to try to assess the severity of alcohol withdrawal. This is one that's very popular and used in many institutions, the Clinical Institute Withdrawal Assessment for Alcohol Withdrawal. And it's essentially a big questionnaire that the patient is asked a number of questions with respect to the alcohol history and how they feel, various symptoms. The scale itself goes up to 67 points. And depending on what the patient scores, they're stratified into whether they have mild withdrawal, moderate withdrawal, or severe. When somebody is felt to have alcohol withdrawal or at risk for alcohol withdrawal, it's recommended that this tool be used hourly to try to make sure that you have an appreciation for how the patient is evolving and then initiate therapy as needed. Now, the scale that I just showed you requires an interaction with the patient. But what if you have a patient who is in alcohol withdrawal who's in the ICU? And that's not uncommon. For where I work, they're going to be intubated and they're probably going to be heavily sedated. It's been suggested that tools like this from the Richmond Agitation Sedation Scale be used to try to use that to assess patients' risk for alcohol withdrawal. We use the RAS tool in our institution in the MICU to assess patients' level of sedation, level of consciousness that are receiving mechanical ventilation. This hasn't been tested widely on patients who are at risk for alcohol withdrawal, but it is something that makes sense to me when somebody's in an ICU and whom they're otherwise sedated. The duration of alcohol withdrawal syndrome is purely correlated to the severity of the withdrawal syndrome itself. So if somebody's having mild withdrawal, the duration actually can be quite short. And if the syndrome itself is limited to stage 1, as listed here, somebody can recover within hours to days. With higher and more severe alcohol withdrawal, then those patients are going to require hospitalization. I think here is where it's important to recognize key decision points. And when somebody is having relatively severe alcohol withdrawal, they're going to be admitted to the hospital. Okay, that decision point is not really something that can be altered very much. But the next one, when you have somebody who then goes to advanced stage 2, let's say, it's suggested that those patients should be then transferred to an ICU. So what is it that we can do to try to manage these patients to prevent their transfer to the ICU? Now I work in medical ICU, like I said. I see what I would consider a fair amount of alcohol withdrawal. And I always wonder what's going on the floor. What are they doing to try to keep these patients from coming into my unit? Because what happens when they go into the ICU? Well, if the patient is able to stay out on the floor, their length of stay typically is described around 5 days. Once they go into the ICU, then the length of stay is going to be probably double, if not longer. So if we can optimize care on the floor, I think that will go a long way towards optimizing care of these patients. Another question that comes up is how long does delirium last? If the patient goes into delirium, how long is that going to last? It's described in the literature as lasting somewhere between 3 and 5 days. The authors of this paper, Carlson, that I have cited at the bottom there, they said some people describe it as perhaps lasting for 2 weeks. In their experience, the most they ever saw was 11 days. I can say that I've had patients easily who have gone 2 weeks lasting delirium, and they are very frustrating to manage because for everything that we throw at them, we can't seem to get control of their delirium. I'm not going to go into detail on this. This is simply iterating what everybody here knows in terms of drugs of choice for patients with alcohol withdrawal. Benzodiazepines have historically been drug of choice, continue to be drug of choice. We continue to use them widely in our institution. The ones up here are chloride epoxide, diazepam, lorazepam, dazolam. My personal favorites are chloride epoxide and diazepam. I like to exploit the agents that have active metabolites because they do allow for a self-taper, so to speak. About 20 years ago, there was a study done that looked at how best to optimize management in patients with alcohol withdrawal syndrome. What they wanted to assess is whether symptom-triggered treatment of these patients versus simply scheduling medications would be better. And so what they chose to do is give benzodiazepines to repeat boluses. Those are the drugs and the doses listed there. And they were given frequently, every 1 hour. Looking at these doses, 4 days of oxide up to 100 milligrams, diazepam up to 20 diazepam. I think those are pretty fair doses. What were the results of this study? Well, the results show that symptom-triggered treatment of alcohol withdrawal syndrome was actually better than trying to schedule a dosing regimen on patients, and then perhaps doing something PRN on top of that. So very aggressive treatment based on the symptom manifestations that patients have. The outcome showed that patients who had symptom-triggered treatment required less drug, fewer side effects, and decreased treatment time. One caveat here is that it didn't include ICU patients. This is a study that was actually done in ICU patients. And this was, again, aggressive symptom-triggered treatment. What these investigators did was try to be very aggressive up front and then see how their concurrent study compared to a historical cohort. If you can't see this, I'll just kind of go over it briefly. But patients started with 10 milligrams of IV diazepam. And then if they're still agitated after an hour, there would be dose escalation. And the dose escalation every hour would get you to a point where you're giving doses of up to 100 or 150 milligrams of diazepam. Okay? If the patient was still agitated after reaching that amount of drug, then they would throw phenobarbital on top of that. And then phenobarbital dosing was escalated. And then if they were still agitated after throwing on the phenobarbital, that's going down this arm here, then they would consider propofol, propofol infusion, and perhaps mechanical ventilation. So their historical cohort that they looked at, they showed that 47% of those patients required mechanical ventilation. And the reason is because those patients had to be treated with a continuous infusion, as listed here, either belatacept or propofol. Now the mean diazepam dose in the first 24 hours, again, pre-intervention was 248 milligrams in that 24-hour period. I don't know how that strikes you, but that strikes me as, that's a pretty good dose. That's pretty significant. And they used phenobarb in 17% of the patients. With the implementation of their aggressive dosing algorithm, the mean dose of diazepam in the first 24 hours was over 500 milligrams. That's a lot of diazepam. I'll say more about that in just a second. 58% of the patients received phenobarb. But by doing that, they were able to realize a significant decrease in the incidence of patients requiring mechanical ventilation. Now, a huge caveat for me, and it's hard to get away from your own personal biases, but about 5 years ago, we had a patient who came into our unit who was going into alcohol withdrawal. Within about a 24-hour period, he had received about 300 milligrams of diazepam. Okay? And that was an eye-opener for me. It's like, wow, that's a lot of diazepam. The patient actually didn't wake up for about a month. It was all because of this protracted response that he had to the diazepam. Now this, to me, is impressive, and they were able to achieve some good results with this, but I do think that one has to be very careful about how much benzodiazepine they're throwing onto a patient. Now, this is, again, reiterating the point in terms of trying to avoid mechanical ventilation in patients. Once a patient with alcohol withdrawal ends up in the ICU, it'd be great if we could manage them without putting them on a vent. Because once you put them on a vent, then it becomes that much more difficult to get them out of the ICU. Now, they were able to achieve a significant reduction, as noted here, 47% to 21.9%. Their rationale for putting patients on mechanical ventilation was once you had to use a continuous infusion sedative. Now, I would ask you, do you think that if you put somebody on a continuous infusion sedative, like belatacept, does that patient have to be intubated? Do they have to receive mechanical ventilation? There was a letter to the editor in response to this study by a physician out in Oregon, with a PharmD, in fact, who said, well, it's interesting and great that you guys are able to do this, but why are you intubating patients just because they're on a lorazepam drip? We have never done that in our experience. We think patients can probably be managed without having to do that. And so it's a good question, and it's a question that I brought up to my physician colleagues in the NICU. Historically, I can tell you that anytime somebody came into our unit who ended up on a continuous infusion sedative, they would be intubated. Okay? We're doing that less now. And in fact, we're doing it with lorazepam. Patients come in alcohol withdrawal with lorazepam, but we don't necessarily intubate them. Which is interesting because we did have one patient one time who began to have metabolic acidosis while on lorazepam, right? You guys are familiar with the open glycol issue. So we had to switch him now. He hadn't been intubated. So I said, well, let's put him on midazolam. And so the nurse said, okay, we're going to intubate him. I said, well, why would we intubate him? And so again, there was that a little bit of a disconnect, in my opinion, where we had kind of gotten to a point where we were used to doing continuous infusion lorazepam, but all of a sudden when you think about using something, another benzodiazepine, after all of a sudden they want to intubate. We actually didn't end up intubating that patient, which is a good thing. So I think that if we can get to a point where even if we're using continuous infusion and not intubating these patients, I think the probability of us decreasing the length of stay in the ICU goes up. This is a study that looked at symptom-triggered management versus just loading patients, okay? Empirically loading patients. 47 patients who were randomized. They were loaded with diazepam, and then the symptom-triggered treatment there with lorazepam. They looked at the CWAS scores, and there was differences in the CWAS scores, but ultimately it didn't really make any difference between either loading the patient or symptom-triggered management. So there was really nothing to take away from that. I threw this up here, not necessarily to go over it, obviously, but as we develop protocols, alcohol withdrawal syndrome protocols, they can get somewhat complicated and perhaps not easy to follow. And I think this is a good example of that. But I think if you use it over time, it might be something that is used and used effectively. This is a pathway that was actually generated at Mass General. I want to take a couple of minutes to go over the Michigan alcohol withdrawal assessment protocol that we have in our own institution. This was developed internally, and it's something that we use often in the general care floors. The nurses were essentially crying out for something to try to help them manage patients with alcohol withdrawal syndrome. But just very briefly, this is the assessment tool. And it's divided into looking at patient symptomatology, CNS symptoms, adrenergic symptoms, or delirium. And they would get scored, and patients would get up to 10 points on this is called the MAWS protocol. This is the treatment that is used. Depending on the patient's score, it is symptom-triggered. So as the patient develops symptoms, then you can treat them accordingly. You can look at the dosing here. I think it's rather modest, especially in the context of some of the things that I just talked about. But I think it is important to recognize, depending on what type of symptoms the patient is having, adrenergic symptoms, clonidine makes sense. It gets back to the pathophysiology of alcohol withdrawal syndrome. Or if they're having delirium, then considering haloperidol. If the withdrawal syndrome is more severe, then you simply ramp up the amount of drug that you use, and that's what this protocol does also. And you can see those are essentially incremental increases in dosing. When this particular protocol was presented at PNT, the intent by those who had generated this protocol was that it be used institution-wide, including in the ICUs. And those of us who were at PNT who work in the ICU said this will never work in our unit because you're not giving nearly enough drug for the types of patients that we see. So we don't necessarily use this. We try to use it in the medical ICU, but often we have to deviate from that because patients require a lot more drug once they end up in our unit. I want to conclude by talking about a couple of drugs that well, this was relatively new, and the other one is not really new, but perhaps new options for us in terms of managing patients with alpha-withdrawal syndrome. Dexmedetomidine, alpha-2 agonist. So again, an agent that can be used to decrease sympathetic drive. There are a number of case reports that show it to have some efficacy. It is suggested that it might be used as good adjunctive therapy to try to get the benzodiazepines down or off. Phenobarbital, we're beginning to use more and more in my unit. I like phenobarbital, and I think that, I used to like chlorine epoxide a lot, but then I saw it fail so much. And so with phenobarb, I think that we're able to get some additional help. I want to talk just briefly about a prospective study that was done in an emergency department, looking at phenobarb loading versus placebo. And their primary, again, this is getting at decision point. The primary outcome was where did the patient end up? Did they end up on the ward, in the ICU, in telemetry? 51 patients per group. And you can see that with phenobarb loading, they had a lot fewer ICU admissions, 8%, relative to 25% of the placebo cohort. There's a whole list of other medications that have been studied, have been tried, case reports, etc. I can tell you that we've used a number of these over time to varying extent and various efficacies. But any one of these are potential options. So in summary, I think it's important to recognize the pathophysiology and pathogenesis of alcohol withdrawal syndrome. I think that helps inform our decision-making in terms of the types of the medication that are potentially used in these patients. Benzos continue to be drug of choice, but I would say don't get stuck on trying to continue to escalate the dose of a specific benzo. I think it makes sense to try to target specific symptoms with other medications. And the symptom trigger, again, is the mode of choice, and then relative